Hi, my name's Mike Dunn. I'm the medical director of the suture and ortho technicians here in the emergency department at Nationwide Children's Hospital. Today we're going to talk about suturing in the emergency department. The goal of this curriculum is that pediatric residents will attain the knowledge, attitudes, and skills to perform simple laceration repairs as indicated by the ACGME 2013 guidelines. By the end of this module, each pediatric resident should be able to list the 5 types of suture material that we use, indicate the appropriate anatomic location for each type of suture, name the equipment needed for suture repair, and describe the appropriate technique for simple interrupted and deep dermal sutures. Most traumatic wounds to the dermis are closed by suture. The repair of these injuries reduces infection and patient discomfort. Restoring the integrity of injured tissue achieves a more functional and aesthetically pleasing scar. Wounds on the face can be repaired within 24 hours, but everything else should be repaired within 12. Now let's learn how to set up our suture tray.
Okay, when you set up a tray, you need to make sure you have your tray itself. You need a bottle of saline, your suture material, your cleansing material. You need something to irrigate with, a syringe, and then a shield that we have here is very handy to keep from splashing everybody. And then a Telfa pad for your dressing after the fact. You can open this up initially, and you'll notice that you've got some sterile labels in there. So you need a pair of sterile gloves. Once you get your gloves on, then you can open this up. You can label whichever side. One of these is going to be labeled Sure Cleanse, the other one's going to be normal saline, which already has on there. And what I always use is B for bubbles. So I always put the Sure Cleanse on the B side. And the C sounds more like an S for saline, so I put saline on the C side. Pour the saline in one side. You can put your Sure Cleanse in there. Let's just twist the top and squirt it down in there. Well, if you can either irrigate sterilely or non-sterilely. Then when you look at these, got a couple of cloth towels. One of these is fenestrated, has a hole in the middle. One of them is not. And then one of these is like plastic that has a plastic bottom on it. We put that down first many times. There's also a papered fenestrated drape as well. Once you get in here, you have a sharps. You can put your needle when you're done with it, stick it in there so you don't have needles laying around. You have 4x4s, they're there, and then your instruments. Your needle drivers are shorter, no teeth inside. Okay, so if you see that up close. And then when you look at your forceps, there's 2 different ones. These have tissue prongs on them so you can grab the tissue and you do less damage than grabbing them with a regular forceps. Your scissors, a couple different things. If you use straight scissors, curved scissors, but either one's certainly fine to use.
The reference for suturing is the Wounds and Lacerations book by Alexander Trott. It is the source of your required reading. Before suturing, we have to give proper anesthesia. Topical anesthesia utilizing lidocaine, epinephrine, and tetracaine, which we call LET, can be used on the neck, face, and scalp areas. Wound infiltration with lidocaine can be direct, in a field block, or with a digital block. The technique for direct infiltration is to insert the needle through the open wound into the superficial fascia, parallel and just deep to the dermis. Lidocaine with epinephrine is the preferred medication for infiltration. Despite outdated dogma, it can be used in digital blocks in the nose and in the ears. However, lidocaine with epinephrine has a lower pH than plain lidocaine, which could cause more pain. So dilute it with a 10:1 solution of sodium bicarbonate. An odd but appropriate phrase is the solution to pollution is dilution. All wounds should be irrigated with between 30 to 100 cc's of normal saline or sterile water. Tap water can also be used, but we do not use it here at Nationwide Children's Hospital. Bite wounds and heavily contaminated wounds can be irrigated with a 1% solution of betadine. The bottles of betadine come as a 10% solution. Irrigation should be performed with a 60 or 30 cc syringe and a splash guard, or you can use the irrigation bottle cap on the bottle of saline itself. Before we start suturing, we have to explore all wounds to make sure there are no foreign bodies or fractures. The wound should be prepared with either betadine or Sure Cleanse by gradually wiping in concentric circles away from the wound. Choosing the right suture depends on where you plan to place them. Subcutaneous sutures, which include dermal sutures, can be monocryl, which is a monofilament and the preferred subcutaneous suture, or vicryl, which is braided. Braided suture has a theoretical risk of increased infection, but it can be helpful for deep bleeding wounds because the braids help the knots bite more. Cutaneous sutures are delineated by what part of the body you plan to place the sutures. While permanent sutures like Prolene and Ethelon can be used, but we prefer absorbable sutures like gut. On the face we prefer fast absorbing, which lasts 5 to 7 days, and on the scalp or the extremities we prefer plain gut, which lasts 7 to 10 days. Chromic gut lasts 21 to 28 days on the skin, so usually we use it only on the mucosal surfaces, where it is broken down quicker through an enzymatic reaction. Make sure you get a suture selection card which can help you decide what size of suture to use. If you don't hold the instrument properly, you will not be able to place a proper suture. The needle driver should be held without your fingers in the loops. You should grasp the needle with the needle driver at the tip, and it should be placed on the shaft of the needle. You want to avoid grasping the point or the swedge. The forceps should be used as a hook, and you should never actually grasp the tissue, which can damage it. One of the most important tenets of suturing is to enter the skin with the suture needle at 90 degrees. This is the only way that you can accomplish an eversion of the wound which decreases scarring. This is only accomplished by holding the needle driver correctly. If you enter the wound at even 70 degrees, the suture path will create a V shape which will invert the wound, making the scar more noticeable. While it is preferred to take one bite through both sides of the wound, if the wound is gaping, you might have to come up through the center. If you do, be certain that you exit the subcutaneous tissue on both sides at the same layer so that you don't create a beveled wound. To create a proper knot, we use the hand over hand technique. First, you wrap the suture twice around the needle driver away from you, grasp the other end and pull towards you, and your hands will switch positions, leaving that throw about a millimeter above the wound's edge. Next, you wrap the suture once around the needle driver towards you and then pull away. Bring the knot so that it forms, but do not make it tight. Next, complete another throw with your hands switching positions, and this is when you make the knot tight by keeping the suture taut for about 1 second. If you continue making the knot tighter and tighter, you could break the suture. Complete a total of 4 throws, making the 4th throw tight like the 3rd. If you place more sutures in a wound closer to the wound's edge, it will decrease wound tension and improve cosmesis. Taking large bites far away from the wound's edge could increase scarring. Your sutures should be spaced as seen on the diagram. It is important to place deep sutures whenever you can fit one in so that you decrease the amount of dead space, which also improves cosmesis. Subcutaneous sutures are anything below the epidermis that decreases dead space. The most important kind of subcutaneous suture is the deep dermal suture. It is like closing the binding of a book. If you've ever seen anyone with stretch marks, it is because the dermis has torn, leaving the epidermis intact. This is why it's so important to place a dermal suture whenever there is room. You start in the subcutaneous area and come up through the dermis at the dermal-epidermal junction. On the other side, you enter at the dermal-epidermal junction and come out in the subcu space. If you go low to high, then high to low, that will keep the knot down below, which will keep the knot from poking through the epidermis and causing more scarring. Before you tie your knot, you have to be certain that both tails are on one side of the loop. If they're not, the knot will be on top of the loop and the knot will spit through the epidermis. If you have done all your sutures properly, you should have a perfectly everted wound edge. An inverted wound edge causes more shadowing, which makes this scar more noticeable. Moving on, let's talk about some advanced suturing techniques. A common type of pediatric laceration is one with a beveled edge. The proper way to close this is to take a larger bite closer to the wound on the thicker side and a smaller bite further away from the wound on the thinner side. Another typical pediatric laceration is a flap. You enter the skin on the opposite side of the flap and you exit in the dermis. You then go through the flap only through the dermis, enter the dermis on the other side and come up through the epidermis. You tie the suture over the skin opposite the flap. Stellate wounds are closed with a modified horizontal mattress flap stitch combined with regular interrupted sutures. Alternatives to sutures include staples, which are easy to place but very difficult to remove, dermabond, which should be applied in thin layers but is not appropriate over joints or hair, The hair apposition technique, where you twist hair together on either side of a scalp wound and place dermabond at the end of the hair to keep the hair together, which keeps the laceration together, but you could also just braid the hair as well. Potential complications to laceration repair, of course, include infection, dehiscence, and poor cosmesis. A referral should be made to a specialist with deep contaminated lacerations, tendon or nerve injuries, deep genitalia wounds, deep or extensive facial injuries, or if there is a long sedation needed. Wound care after repair is also important for cosmesis. It's important to keep the wound edges moist with bacitracin antibiotic ointment for at least 48 hours after repair for re-epithelialization. You should wash wounds with soap and water 12 to 24 hours after repair. You should also never use hydrogen peroxide because it accelerates fast gut absorption and has never been shown to be bactericidal. You should also encourage your patients not to swim or soak their wounds in water until 7 days have passed. Antibiotic ointment should only be used for 2 to 3 days because of the potential for fungal infections. At Nationwide Children's Hospital, we prefer bacitracin over Neosporin because of the potential for allergy. An occlusive or semi-occlusive dressing should be applied for the first 48 hours in order to keep the wound moist for re-epithelialization. Remember that air is bad, so use a Telfa pad. Your primary teaching should come from the attendings, fellows, and senior residents. The suture techs are also a wonderful resource. They're really good at this. Also remember to ask for child life so that they can distract the patient while you repair the wound. I hope you've enjoyed this exciting lecture. But before we go, we should review our objectives. We need to be able to list the 5 types of suture material, indicate the appropriate anatomic location for each type of suture. Both of those things can be found on your reference card. We also need to be able to name the equipment needed for suture repair and describe the appropriate technique for simple interrupted and deep dermal sutures. Here are references that are outside of the Wounds and Lacerations book, which I hope that you will read. Thanks again, and I hope you enjoy your procedure shifts.